Hello, good morning, colleagues, good morning, everyone. Welcome to this very early morning symposium. I think the title is Demystifying Cold Agglutinin Disease. I haven't invented that title myself, but I think it's a good title. For in old literature, it is often repeated and repeated and then repeated again as a mantra that cold agglutinin disease is a poorly understood disease. I think today, cold agglutinin disease is a fairly well understood disease, and Dr. Weitz and I will try to explain that in more detail. The chairs and speakers and panelists will be Berentsen Weitz and myself. As for myself, I am a Norwegian clinical hematologist who has done quite much work about cold agglutinin disease and authored several papers, both on the disease characteristics and the B-cell directed therapies, and I have been participating actively with respect to the complement-directed therapies, which is going to be the main focus on this symposium. Dr. Weitz is a professor at the University of South California in Los Angeles, and she has been working quite much with complement-mediated hematologic diseases like PNH, autoimmune diseases, and including cold agglutinin disease. And she has also been a very active participant in the complement-directed trials. Thanks to the Medical Learning Institute and Peer Review for providing this session, and to Sanofi for their generous grant for this endeavor. If you haven't already completed the pre-talk evaluation, the pre-event survey, please do so. You will be able to do that on your iPads. And as a reminder, look out for additional follow-up polling questions during the presentations, because there will be some, and we think they are very illustrative. And please submit questions, and we will try to answer them in the Q&A session as far as the time permits. So don't be afraid of asking questions. If you think the question is too stupid, that usually means that it's stupid for most of the people, and that there's a need of asking that question. So I think without very much further introduction, I will start to present the first subtopic and give a closer look at the new insights in the pathogenesis of cold agglutinin disease. Cold agglutinin disease is a complement-driven hemolytic anemia, and you see we have classified it among the secondary complement disorders, in which we have most of the autoimmune hemolytic anemias, like cold agglutinin disease and secondary cold agglutinin syndrome, paroxysmal cold hemoglobinuria, or PCH, which is an extremely rare disease, at least in adults. And proportion may be about 50% of the warm antibody autoimmune hemolytic anemias, the WAIHA, will also be within this category. And to start with, I would like to mention that today we distinguish between cold agglutinin disease and cold agglutinin syndrome. Cold agglutinin disease is the well-defined clinical pathological disorder that we are going to talk about in this session. Cold agglutinin syndrome is a heterogeneous but similar picture, secondary to other clinical diseases, and we are not going to talk about cold agglutinin syndrome. So, classification of autoimmune hemolytic anemia. First, we have the warm antibody type, or WIHA, which can be primary or secondary. Second, we have the cold antibody types. And a cold antibody autoimmune hemolytic anemia is not synonymous with cold agglutinin disease. In that group, we have primary cold agglutinin disease, or just cold agglutinin disease. And we have the secondary cold agglutinin syndromes, secondary to, for example, infections like mycoplasma or Epstein virus infections. And we have secondary cold agglutinin syndromes associated with malignant disease, not least with overt B-cell lymphomas. And then we have the very, very rare paroxysmal cold hemoglobinuria. And there are also mixed warm and cold autoimmune hemolytic anemias. The frequency is somewhat controversial because it depends on the definition and which criteria you choose to call it mixed. The optimum temperature for the reaction between antibody and antigen in cold agglutinin disease is below 37 degrees, and the optimum temperature is often about 3 to 4 degrees. And you can wonder why we are able to produce antibodies with an optimum temperature that far below the normal body temperature. And I think it's a question of evolution. It's a remnant from animals that was similar to the sharks. This slide says that about 50% of autoimmune hemolytic anemias are cold agglutinin disease or cold agglutinin mediated hemolytic anemias. I would rather say between 15 and 30%. So, what are the different biomarkers distinguishing the different cold reactive immunoglobulins? In cold agglutinin disease, it's a question of immune hemolysis initiated by at low temperatures. In PCH, it's an intravascular hemolysis due to a cold-sensitive antibody. And then we have cryoglobulinemias, which are not hemolytic anemias, in which immunoglobulins can precipitate in the cold. The active antibodies in cold agglutinin disease are called cold agglutinins, as everyone knows. In PCH, we have the Donat-Landsteiners antibodies, and the cold agglutinin disease, the cold agglutinins and cold agglutinin disease are almost invariable of the IgM class. Rarely, it may be IgG. Cold agglutinins of the IgA type do exist, but I would be almost 100% sure that they do not give rise to cold agglutinin disease because they are not able to activate complement. So then we will have a look of the mechanism of disease, and to be correct and not conceal anything, the pathogenetic mechanisms does not start where we see in this slide, because cold agglutinin disease is a bone marrow clonal lymphoproliferative disorder, not classified as a malignant disease, but still as a clonal disease, and it's recognized as a clonal lymphoproliferative bone marrow disorder by the recent revision of the WHO classification this year. So from this year, cold agglutinin disease is listed in the WHO classification as a clonal lymphoproliferative disorder. It can be easy to determine it, to recognize it, but sometimes it's difficult to find it by routine methods. Well, those clonal lymphocytes produce the cold agglutinin, and when the cold agglutinin binds to red blood cells, it will agglutinate the red blood cells, so you will get agglutinates, lumps, which will then dissolve through the passage after rewarming to 37 degrees in the central circulation. The antigen-antibody reaction activates a complement protein complex C1 or C1QRS, and the next step is that you get activated C1s, which is a serine protease. C1s splits in turn first C1 and then C2, and you get the complex of the split products, the C3 convertase, that splits C3 into C1a, which is a soluble protein with anaphylotoxin properties, and C3b, which remain attached to the red blood cells. Before this, the cold agglutinin has detached from the red blood cells. From this point, there are two possibilities. C3b can combine with C4b and C2a to C5 convertase. C5 is bound to the red cells, and the terminal complement pathway or cascade is triggered, and you get the formation of the membrane attack complex, or C5b29, on the red blood cells with intravascular hemolysis. But in most patients with cold agglutinin disease, at least in stable disease, and at least in the absence of acute exacerbations, there is another pathway that is more important. C3b opsonized cells are attacked by phagocytes in the mononuclear phagocytic system, in the liver much more than in the spleen. And we have phagocytosis of opsonized cells, which is called extravascular hemolysis. Some cells will survive, and on the surviving cells, C3b is further metabolized to C3d, which in some way protects the cells from further degradation. So the surviving cells will escape and will be labeled with C3b, which can be used for identification in the laboratory by the monospecific direct antiglobulin test for C3d. Another interesting feature, and it's a quite recent finding, is that complement receptor CR1 is downregulated in complement disease. CR1 is a membrane-bound complement inhibitor acting at several targets, but paradoxically, it is also a facilitating factor for the opsonization of cells with C3b. So it has multiple targets and multiple effects on the complement system. And as I said, this is a new finding, and we not yet know the clinical and hematological consequences. This finding will be presented from my very good colleagues Agnieszka Małeczka from Norway in this ASH at the poster on, and I think it is on Sunday. And I will also recommend another relevant poster by my very good colleague from Washington, US, Catherine Broom, who will have a poster on hemolytic markers and thromboembolism and cold agglutinin disease, because thromboembolism is to a very high degree a consequence of the complement activation, I think. So now, to further illustrate the mechanisms of complement-mediated hemolysis, we will see a very short video.
Cold agglutinin disease is a rare form of autoimmune hemolytic anemia in which the immune system mistakenly targets and destroys red blood cells. In CAD, abnormal cells of the bone marrow produce immunoglobulin M antibodies called cold agglutinins that can attach to red blood cells. This causes the blood to agglutinate in cool conditions. People with CAD commonly experience agglutination in the peripheral circulation, such as the fingertips. As the blood enters the central circulation, it becomes warmer. The cold agglutinins detach from the red blood cells, and the agglutination resolves. But re-exposure to cool conditions reattaches the cold agglutinins to the red blood cells, inducing agglutination. The short-term presence of the antibodies on the red blood cells forms a complex that activates the classical complement pathway. The activation starts with C1, initiating a cascade of immune responses. Next, complement C3b binds to the red blood cells, marking them for destruction, which may occur in either of two different ways. The first way is that the marked red blood cells undergo phagocytosis in the liver, where monocyte macrophages cause extravascular hemolysis. This is the primary way red blood cells are lost in CAD. The second way is that C3b can also trigger terminal activation of the complement pathway through C5b, which directs its membrane attack complex against the marked cell, resulting in intravascular hemolysis and premature destruction of red blood cells in the circulation. Whichever path is taken, the complement system can destroy red blood cells as thoroughly as if they were bacterial invaders.
Well, thank you, Perview, for the nice video, very illustrative. And now I have landed the first part of the presentations before schedule to almost sight the pilots on my flights to the US. And I will give the word to Professor Weitz for the first part of the next presentation.
Thank you. All right, so when should you suspect cold agglutinin disease? Those patients who have anemia certainly should be part of the workup, but particularly if they have skin changes. If they have acrocyanosis, Raynaud's phenomena, if they have livedo reticularis. And remember, those are going to occur in cold exposed areas. You're not going to see it on the abdomen unless they're unclothed. So you're going to look for peripheral evidence of agglutination and cold-induced circulatory symptoms. So things that you want to look for, again, the vast majority of patients are going to have maybe acrocyanosis with Raynaud's type phenomena, not necessarily cutaneous necrosis. That's pretty rare, but does occur. Livedo reticularis. Also look for the nose and also the ear. The tips of the ears are common places that you might see some of the acrocyanosis. Pain and discomfort on swallowing cold foods. You wouldn't think about that. That's a central place, but these patients will complain about that. A lot of symptoms are present in these patients even before they have an exacerbation of their cold agglutinin disease. Fatigue, tiredness is a very common feature, and it's a feature we see in a lot of other hemolytic disorders. And it's really independent of the degree of anemia. It's really cytokine mediated. They may have decreased stamina, they may have increased weakness, they may have shortness of breath, particularly if they're very anemic or if they have thrombosis, and they may have evidence of acrocyanosis. When they have an episode of CAD, then their fatigue definitely increases. You could see there's a 10-point increase, 10% increase compared to before. They have increased weakness. All of these are the same, and they may even have dark urine depending on the degree of intravascular hemolysis. So factors that trigger off CAD episodes: cold temperatures. Now, in Southern California, for example, we don't see exacerbations of CAD during the summer because we're pretty warm. But this time of year, we will see more cases. So we had 2 patients who presented in the last 2 weeks with exacerbations of their CAD, and that's because the local temperatures are down to below 50 in some parts of the city. So again, cold temperatures. Dr. Berentsen, Dr. Ross see many more patients than I do because they live in colder climes. Wintertime, again, as I mentioned, because of the temperature changes. Air conditioning. So temperatures are kept around 78 to 72, and that may be low enough for patients to experience exacerbations in their CAD. Sudden changes in temperature. So I have a patient, for example, who goes out to do her morning jog, and when she gets sweaty and then she stops running, she will notice cold symptoms. She'll get evidence of Raynaud's, and she'll have evidence of acrocyanosis as she cools down, especially if there's a wind, if there's a breeze, and that causes sudden cooling. Infections, which increase your complement activation, surgery, et cetera. When I was a fellow, we had a patient who died in the OR who had cold agglutinin disease because they didn't read our note and they didn't warm up the operating room. And the operating rooms are kept very cold. So that's a really important thing to remember if your patient's going to have surgery. Dr. Broom has also published this very interesting analysis that looked at the Optum database and thrombosis risk in cold agglutinin disease. We always thought of CAD as just a hemolytic disease, but like all complement-mediated disorders, there's an increased risk of thrombosis due to the complement activation. It's really driven by the complement. And you could see most of the events, almost a 3-fold increased risk in venous events, but also arterial events do occur. And if you look at the characteristics of cold agglutinin patients, you can see the vast majority will have evidence of hemolytic anemia with low-grade circulatory findings. They may have, or they may not have any manifestations, but about 21% will have grade 2 to 3 circulatory findings with their hemolysis, and some will have a compensated hemolytic anemia, so they have a pretty normal hemoglobin, but will have evidence of circulatory symptoms as an important manifestation of their disease, even with a relatively normal hemoglobin. So we have a patient. Now remember, cold agglutinin disease does occur in an older population. So these patients tend to be 65 and up, if not closer to 80. And this woman in particular is pretty classic for a patient. 81 years old, admitted to the hospital with severe fatigue, and she has a 4-month history of anemia. She previously was very healthy, walked every day, did her activities of daily living. She had mild hypertension, which was treated, but she had evidence of intermittent episodes of confusion. but she didn't have any cold circulatory findings or symptoms. On presentation, her hemoglobin was 6.2. Her LDH was 647, which was elevated. Bilirubin was elevated. Haptoglobin was low, and the reticulocyte count was modestly increased, probably inappropriately low for the degree of hemoglobin. So, rethinking your original analysis, your original choice, would you think that this woman has cold agglutinin disease? Could she have cold agglutinin disease? Okay, so getting there. Yeah.
Yep.
Okay. All right. So if you have a patient that you think has cold agglutinin disease, how should you work it up? So that's why we have the lab. But processing these specimens is very tricky. And I'm sure all of you have sent for a cold agglutinin titer, and it's come back negative. And the main reason for this is that the specimens are usually not handled properly. For example, even drawing a CBC, you really need to have a pre-warmed tube, or by the time the blood gets into the tube, which is cold, it's going to start to agglutinate. And so you need to let the lab know what you're looking for, because the technicians won't know, and you'll want to have them handle the specimens properly. So for blood counts, you want a pre-warmed tube if possible, and then they put it in the heat block or in the water bath and then take it to the lab. The same is true for the cold agglutinin titer, where you need serum or plasma, have a pre-warmed tube, it's carried, hand-carried, or put in the warming bath, and then when the clot's removed, then you can do your titer. But it needs to be kept warm. And if it's being spun in the centrifuge, it's in a warm centrifuge. For flow cytometry, they usually just pre-warm before the analysis. And I'll stop there and I'll turn it over to Dr. Berentsen for the diagnostic algorithm.
Yes, then we have already heard something about diagnostic, and I'm going to continue with an attempt to present the diagnostic algorithm. And first, I know that most people in the US are not used to looking so much in the microscope. In Europe, it's heterogeneous. In the UK, for example, and in my country, we do the microscopy of blood smears and bone marrow aspirates by ourselves. And a typical finding in cold agglutinin disease is agglutination in the blood smear. And you can also see it at the macroscopic level, as illustrated by the test tubes here. Here comes the algorithm. To establish a diagnosis of cold agglutinin disease, you have to have hemolysis, and the look for hemolysis can be triggered by the presence of anemia or by the presence of cold-induced circulatory symptoms, like Dr. Weitz mentioned. And if the hemolytic markers, the LDH, bilirubin, often indirect bilirubin, and haptoglobin, and often retics indicate hemolysis, you have to proceed with assessing procedure can differ between labs, but often the dilutions are continued until 1 to 5/112. And if there is still a positive test, you have to make further dilutions until the test is negative. And to each dilution, you add group O red cell suspension and incubate for 4 degrees, and you look for agglutination, and the titer is the dilution, or the titer is the inverse of the dilution that displays the highest dilution that displays agglutination. So we can summarize. To diagnose cold agglutinin disease, the patients must have chronic hemolysis. There must be a positive polyspecific DAT. The monospecific DAT must be strongly positive for C3d. Usually it's negative for IgG, but it can be weakly positive for IgG in up to 20% of the cases. Don't ask me why, but because I don't know. The cold agglutinin titer must be high, and we used to use 64 as a cutoff. There must be no overt malignant disease, and if these criteria are present, the patient has cold agglutinin disease, and we try to confirm the clonality, if possible, by serum protein electrophoresis, which will show monoclonal IgM or bone marrow biopsy. At least we should do that before treatment, because today, and not least today, it can affect the choice of treatment. I don't remember if I have mentioned serum. When you prepare serum for serum protein electrophoresis, you must use the same precautions as Dr. Weitz mentioned for serum for cold agglutinin titration. If not, you will not find the monoclonal IgM. So, back to our patient, which has who has been presented to you. You have seen some of the results before, but some hours after admission, this is a real patient whom I treated. Some hours after the admission, we also had a slightly elevated serum IgM by 3.3 grams per liter. I think in the US you say 33 grams per deciliter. Is that no?
That's okay. You can.
Yes, you say milligrams per deciliter.
Milligrams per deciliter.
33, yes. The patients also turn out to have a monospecific DAT, strongly positive for C3d. And now we can rethink the next question. It's still the same patient, but she had an electrophoresis positive for a monoclonal IgM, a slightly elevated total IgM, and a positive DAT for C3d. And what would be the next step? Yes, people are suggesting a polyspecific DAT, but we saw the results of the polyspecific DAT because when the monospecific DAT is positive for something, the polyspecific DAT will also always have been positive for something. So that's right, you must have a polyspecific DAT, but I think the exact next step after what we had shown will be the cold agglutinin titer, as many people are saying. So just to finalize this part of the talk, before treatment of the patient, I do it also in primary diagnosis, but at least before treatment, we should try to find the monoclonal lymphoproliferative disorder. It usually shows tiny intratrabecular infiltrates, bi-cell infiltrates, but it can also be just scattered clonal cells. And today, this condition is classified as a distinct clonal LPD by the WHO classification system. And then I will turn the podium back to Professor Weitz. Please, Eileen.
Thank you. All right, so we have our patient with CAD. What shall we do about it? And previously, we only had best supportive care, which included transfusions. Steroids are of no value in patients with CAD. So we have cold agglutinin-mediated disease. You really need to determine whether it's primary or secondary. There are a variety of other supportive measures we could consider, including ESAs. Now, it depends, obviously, on the retic response. In this particular patient, the retic response was not particularly good. So you could consider using an ESA. And these, again, tend to be older patients, and they may not have, their kidney function may not be as good, and so there may be a role for ESAs. Plasma exchange or plasmapheresis. IgM's a big molecule, so it's easy to remove. But plasma exchange is somewhat cumbersome. IVIG has been used, and blood transfusions. One thing I do want to point out is if you're going to do blood transfusions, don't forget the blood warmer. You need to warm the blood before it's infused. And if you ever walk into a CAD patient's room, it's 20 degrees warmer than outside, than the hallway. And that's because of the blood warmer. So you want to make sure that the blood warmer is used. So there are a variety of other treatments that we could consider. We can watch and wait, but obviously if the patient's symptomatic, you don't want to do that. And then there are patients who have some symptoms, and we can treat the underlying lymphoproliferative syndrome, or we can affect the complement activation. And part of the decision for treatment depends on which of those is the more active component. So we have rituximab, we have sutimlimab, we have eculizumab, we have plasmapheresis as options. Rituximab has been used to treat cold agglutinin disease in a single-arm prospective study. They had 27 patients with CAD and hemolysis and symptoms, and they received rituximab in the classic lymphoma manner, and only 3% had a complete response, so not the best response. 51% had a partial response, which did include an improvement in the hemoglobin by greater than 2 grams. So they may not be normal, but they had improvement. And there was a reduction in the IgM titer in the cold agglutinin titer by 50%. But 46% of patients in this study did not have a response, and it took 1.5 months, 6 weeks, to see a response. So in the meantime, the patients were still in extremis. The duration of response was just shy of a year, and you could retreat the patient. And interferon's been added in some cases. It was well tolerated, and it does have some effect. What about combining it with chemotherapy for low-grade lymphoma, such as with bendamustine? And in a prospective, the Nordic trial, a prospective trial, 45 patients with CAD and anemia and symptoms, cold symptoms. They got 4 cycles of rituximab, the classic rituximab, and got bendamustine as well at 28-day intervals. Much better response rate, complete response rate in 40% of the patients. And it also alleviated some of the cold symptoms, reduced the IgM, and cleared the bone marrow. A third of patients had a partial response, and 29% of patients did not respond. But a third of patients had grade 3 to 4 neutropenia and really required a dose reduction. And remember, these are older patients, so neutropenia in an older patient is a recipe for disaster. Bendamustine is active. It's relatively safe with the exception of neutropenia. And these patients did have sustained remissions for up to 40, with 70% being in remission at 84 months. So it has a very long remission rate. Now, a lot of attention in recent years has been paid to the complement system. I won't go through the whole complement system with you, but just to say that we know that there are a variety of different points in the complement cascade that can be addressed to limit the effect of the complement, to interrupt the complement cascade. And we have I think we have a video now for, yeah.
The classical complement pathway plays a central role in CAD. Elements in this pathway are activated sequentially, suggesting multiple points of intervention to halt the disease process. Among these elements are C1, C3, and C5. Eculizumab is an anti-C5 monoclonal antibody that inhibits the cleavage of C5 into C5a and C5b, preventing the formation of the membrane attack complex, the final step before the red blood cell is destroyed by intravascular hemolysis. Before sutimlimab was available, eculizumab was recommended off-label for emergency treatment of hemolytic crises since it can alleviate hemoglobinuria within 24 hours and stop intravascular hemolysis within 4 weeks. Only a small number of red blood cells are destroyed by intravascular hemolysis in CAD. So if we want to stop extravascular hemolysis, we need to move upstream in the classical pathway. The C4b-C2b complex acts as a C3 convertase, cleaving and activating C3 in the classical pathway, thus creating C3b, the tag that marks red blood cells for destruction. Pegcetacoplan inhibits C3 cleavage, normalizing laboratory measures of extravascular and intravascular hemolysis and increasing hemoglobin within weeks. However, the cascade of immune responses in CAD begins even further upstream, with C1 activation. Sutimlimab is an IgG4 monoclonal antibody that binds C1s, a serine protease that cleaves C2 and C4 upstream of C3 in the classical pathway, and is the first approved complement therapy for CAD. Sutimlimab does not affect the activation of C3 and C5 through the alternative and lectin pathways. Still, it improves laboratory measures of classical complement pathway activity in 1 week, increases hemoglobin within 3 weeks, rapidly inhibits hemolysis, and reduces fatigue. Sutimlimab also reduces the need for blood transfusion.
Okay, well, that was nice. They did it for me. So what have we learned about the different points of interruption of the complement cascade. So the DECADE trial was using eculizumab. It was the first prospective trial of a complement inhibitor in CAD. It was a single-arm intervention, 13 patients. They had, and they were not able to be treated for 4 weeks prior to the complement intervention. And they got the classic treatment like you would treat for PNH with 600 milligrams weekly, then followed by 900 milligrams every other week. It was a 26-week treatment trial. And then they had an 8-week washout and observation phase. You could see that the LDH was reduced. The hemoglobins increased just by about 0.7 of a gram. There were 11 patients who became or maintained transfusion independence, which is important, but there was no effect on the cold circulatory symptoms as you'd expect. There were 13 AEs in 4 patients, and it was deemed that those were possibly treatment-related. There were no meningococcal infections. So eculizumab does reduce hemolysis and transfusion dependency in the majority of the patients they looked at, but it had no impact on the cold circulatory symptoms. What about interrupting at C3 and the generation of C3b and subsequently the extravascular clearance? We know that most of cold agglutinin hemolysis is extravascular. So there was a phase 2 trial, 48 weeks, open label, done in the US and Brazil, 12 patients with CAD, 9 with warm autoimmune hemolytic anemia, and the PEG was given every day at 270 or 360 milligrams per day, sub-Q. At day 56, they did an interim analysis, and this was presented at the British Hematology meetings several years ago. And the hemoglobins increased from 8.7 to 12.1. That's a huge increase. The LDH, retic counts, and indirect bilirubin all returned to normal levels. 75% of patients had some AEs, mostly grade 1 to 2, and they were deemed not related to the pegcetacoplan, although I suspect that there were probably some related to the pump itself, since it was to sub-Q, and there's a learning curve to use the pump. There were no grade 3 or 4 AEs that were considered related to the treatment. So pegcetacoplan can increase the hemoglobin in CAD within the first few weeks of treatment. It reduces intravascular as well as extravascular, primarily extravascular hemolysis, and it appears to be safe and it's well tolerated. And there is a phase 3 trial that's going to be presented on Sunday, so that's worth looking at the data. And Dr. Cooter is also going to be doing a joint ASH FDA symposium on Monday on cold agglutinin disease. All right, what about sutimlimab? So sutimlimab acts at the level of C1s, so it acts much higher in the complement cascade. It doesn't inhibit the lectin pathway, it doesn't inhibit the alternative pathway, and it doesn't theoretically inhibit the terminal complement pathway. So in theory, it should be much safer with many fewer infections. The cadenza trial was a randomized clinical trial in CAD, 42 patients with anemia, but no recent transfusion requirements. And they were given sutimlimab based on their weight, either 6.5 or 7.5 milligrams on day 0 and day 7, and then every 2 weeks thereafter. And this was a 26-week analysis. 73% of the patients met the primary composite endpoint of increased hemoglobin and without a transfusion requirement and without the need for any other intervention. So very effective. The laboratory measures of the complement system were improved within a week. The symptomatology that the patients reported was improved within a week of treatment. CAD symptoms were reduced 50% from baseline. And again, the fatigue scores in particular were improved within a week of starting therapy. But the cold symptoms, the Raynaud's, et cetera, persisted. So the conclusions, sutimlimab reduced hemolysis and improved the anemia, reduced the fatigue, and it's very well tolerated, and the adverse events were no different than you would see in the older population in general. What about patients who are transfusion dependent? These tend to be a sicker population. And again, in the Cardinal study, 24 patients with confirmed CAD, anemia, and a recent history of a transfusion. Sutimlimab was administered the same way as in cadenza. And 54% of the patients met the primary endpoint, so they had greater than a 2-gram increase in the hemoglobin, did not require transfusion or any other CAD intervention. 71% did not receive a transfusion from week 5, so it does take a while for the patients to be loaded with the drug, so from week 5 until the end of treatment. So again, meaningful reductions in fatigue were observed within a week, and that really correlated with the suppression with the Wieslab score, with the suppression of complement activity. Bilirubin normalized by week 3, and 29% had at least one SAE, but none were related to sutimlimab. So the conclusion, sutimlimab rapidly halted hemolysis, increased hemoglobin, reduced fatigue, and had a favorable impact on hemoglobin, bilirubin, retic count, and fatigue, and was maintained for at least 1 year. If you look at the patient-reported symptoms and fatigue, you could see that at week 26, most of the patients had improvement in their symptoms, either very much improved or much improved, minimally improved, and very few had no change, and none reported their symptoms as being worse. And if you look at the fatigue scores, it's very similar to that. Again, 26% had improvement in their in the fatigue scores, and most of the patients had mild to moderate fatigue. What's the indication to use sutimlimab in CAD? You really have to decide which is the more acute process going on with the patient. Remember, these are low-grade lymphoproliferative disorders versus acute hemolysis. So if the patient has high-grade bone marrow involvement, then you're going to probably treat with a B-cell-directed therapy. But in this case, for most of the patients, because they don't really have that, you're going to look to treat for the acute exacerbation, for the acute anemia, for the symptomatology, and you may want to consider it as a bridge to treatment. If the patients have failed immunochemotherapy or it's contraindicated, you may want to consider sutimlimab as well. If you look at the differences between rituximab and bendamustine, versus sutimlimab, the response rate in sutimlimab is extremely high, okay? It's also high in rituximab bendamustine. The duration of response in Ritux bendamustine is very long, whereas sutimlimab you have to keep giving, it's short. The duration of treatment, again, Ritux bendamustine you may give X number of cycles of Ritux bendamustine, but for sutimlimab you have to continue treatment. The onset of the response is very rapid with sutimlimab, within the first week, and it's much slower for the chemotherapy and Ritux. The circulatory symptoms don't really improve with sutimlimab, but they do with the chemotherapy. Toxicity, there is more toxicity, as we talked about. Again, a significant 29% of patients had grade 3 to 4 neutropenia in this old population, whereas the toxicity of sutimlimab is remarkably low. Cost, they're both expensive, so I don't know that there's that much difference, but obviously sutimlimab is a much newer agent, so it's going to be more expensive. And here are some of the abstracts that you can expect that you might want to check out. Improvement in the patient-reported outcomes in the extension trial, and also the Part B of the cadenza trial, and the concomitant use of sutimlimab and COVID-19 vaccines in patients with cold agglutinin disease. I think that's a very relevant issue for patients these days. And then the joint session, novel therapies for cold agglutinin disease on Monday. So here's our patient, and you could see we've completed her workup. Her cold agglutinin titer was markedly elevated. C4 was not detectable, so she had ongoing complement activation through the classical pathway. So rethinking your choice in this physically fit 81-year-old with severe fatigue, well-controlled hypertension, 4-month history of anemia, evidence of hemolysis, but no cold circulatory symptoms. She's been given the diagnosis of primary CAD, so what treatment would you choose for her? That's interesting, yeah. Okay. Well, a lot of people would take sutimlimab, but more people would take Berentsen bendamustine. And nobody would take prednisone. Yes. Okay. All right, so this patient was treated before sutimlimab was available, and she actually got Berentsen bendamustine, and she had a great response. And she's been in a sustained remission for over 5 years. Second and third line therapies, again, if they've received rituximab or they've failed rituximab and bendamustine, or if they've relapsed, certainly you could consider a clinical trial for these patients, or you can place them on sutimlimab, which is approved, at least in the US, it's FDA approved. All right, so rethinking your choice. Oops, did I go the wrong way? No. Okay. She has a relapse, finally, after 5 years. Hemoglobin is 7.4. What treatment would you choose for her? Eculizumab, ibrutinib, sutimlimab, or another treatment, or I'm not sure. So the vast majority would choose sutimlimab. Okay, all right. Some key takeaway messages. Again, CAD is a rare but very burdensome disease, complement-driven, mediated or complement-driven autoimmune hemolytic anemia. Treatments for CAD are really different than those we would use for warm-mediated hemolytic anemia. Bendamustine can induce long-term remissions. They don't work for all patients, but they certainly do have significant immunosuppressive effects, and particularly in the COVID era, that's something we worry about because they don't respond well to vaccines. And sutimlimab is the most extensively studied complement inhibitor for CAD. And with biweekly infusions, it normalizes the hemoglobin and reduces the need or eliminates the need for blood transfusions. And I think that's all we have. And we have a bunch of questions that you've already sent in, and then we'll take some additional ones from the audience.
Yes, I think we can open. We have many questions already submitted. So if someone in the audience has a very important question, we can open with that and then take questions which you have already sent. I have some problems in seeing people with that light.
Yeah, we absolutely can't see any faces over there.
I don't see any hands.
So if you have a question, just go to have one of the people bring the microphone to you. We'll try to sort it out. It's really hard to see.
I see no questions at this time.
Okay, well, we'll try to tackle some of the questions. We had a lot of questions. Okay.
Yes, there is one question, one of the submitted questions. Would you give maintenance rituximab after bendamustine rituximab? No, and there are two reasons for that. First, rituximab maintenance has not been systematically investigated at all in cold agglutinin disease. Second, if the rituximab bendamustine treatment was successful, the expected duration of response is so long that I wouldn't consider rituximab maintenance.
And it would only contribute to the immunosuppressive effects that the patient would experience.
Definitely.
Without benefit. Someone asked what the boundaries are between Waldenstrom's and CAD. So Waldenstrom is a true lymphoma, and hemolytic anemia is not as big a component of that, even though they have a high IgM. They don't have cold agglutinin disease. So in cold agglutinin disease, the antibody, the IgM, is directed to the red cell.
Yes, I agree. And an additional distinction is there are some histopathologic morphologic features that differs. There are cytogenetic features that differ. You can learn more of that by seeing the poster by Agnieszka Małeczka at the main congress. And the MYD88 L265P mutation, which is positive in virtually all cases, or at least in more than 19% of cases in Waldenstrom, is usually not present in cold agglutinin disease. So that's, in practice, a good distinction. And then there is a question, any indication for anticoagulation as primary prophylaxis? Question mark. If thrombosis, unlimited anticoagulation indicated as long as hemolysis is going on? Question mark. NOAC or vitamin K antagonists? Could you answer that?
Yeah, we don't have a lot of experience. There's no data. We do know that if we treat, especially if we treat with a complement inhibitor, you shut down the hemostatic activation. So it's another advantage of using something like sutimlimab or pegcetacoplan or eculizumab in these patients because it'll shut off the hemostatic activation and you won't need to anticoagulate. If they're not treated or if they have ongoing hemolysis, we would look at D-dimers. That's the only measure you have of hemostatic activation that you can get, unless you have a research lab. So you can look at that, and if the dimers are elevated, you could consider using prophylactic anticoagulation if there's no evidence of clot. If there's evidence of clot, then you have to anticoagulate.
And then we have the next question, how to differentiate between CAD and CAS. And I was invited to give a virtual talk in Japan on that topic, and I also did the same in Austria, and I talked for half an hour. So I think I would be somewhat shorter now, but it's a good question. And in most cases, the distinction is very easy. In CAS, you have in most cases a hemolytic anemia secondary to a mycoplasma infection or an Epstein-Barr virus infection or recently to a COVID-19 infection. Or you have a hemolytic anemia secondary to an aggressive B-cell lymphoma, and the distinction is then easy. The distinction can be more difficult if you, for example, have the patient diagnosed by the pathologists with an SLL, that's a CLL lymphoma in the bone marrow, or lymphoplasmacytic lymphoma, as was mentioned in another question. Then the most controversial may be if the patient is diagnosed with a lymphoplasmacytic lymphoma, because if that diagnosis is correct, the patient will usually have Waldenström. But we also know that if these patients are diagnosed with an LPL, lymphoplasmacytic lymphoma, by decentralized multiple pathology laboratories, and the diagnosis is LPL, if you have a centralized revision by a pathology lab used to diagnose the cold agglutinin-associated lymphoproliferative disorder, the diagnosis will often be revised. So I think that the histologic LPL diagnosis, Waldenström, is often overdiagnosed in these patients. Most of them turn out to be MYD88 negative, and most of them are cold agglutinin-associated LPD, not Waldenström. And then, do you classify patients based on severity? If so, how do you treat them? Rituximab, combo, or sutimlimab? I think either of us could.
Yeah, I think you want to look at what's the severity. If it's because they're hemolyzing, then you want to think about using sutimlimab in that setting. Or some, since that's the only approved drug, I'm going to use sutimlimab, because that's going to shut off the hemolytic process within a week. Whereas the chemotherapy takes a while, it takes at least 6 weeks to see benefit. So if the severity is because they have a lymphoma, and the lymphoma is what's making them sick, then you would go with the chemotherapy first. Or there's no data on, or there's very little data on combining treatment. Actually, there is a really interesting question that I thought we should address. And can you use sutimlimab preoperatively to mitigate the risk of hemolysis during surgery? That's a fascinating question.
Yes, and maybe we don't know for sure, but
don't.
logically it should be feasible. And there are, in fact, one case report where it worked very well. So probably the answer is probably yes.
You would
And to add, there is another case report that indicates that if sutimlimab is not available, you may also try eculizumab, because if the patient has a severe exacerbation during or after surgery, it is an intravascular hemolysis, and sutimlimab may be effective in that case.
Right, right. So,
Sorry, eculizumab
Eculizumab.
may be effective in that case.
so one thought is that, assuming this is not emergency surgery, you could at least get 2 doses of sutimlimab in so that the levels are good before the surgery, and make sure, what we do with PNH patients, for example, is make sure their ECU gets in the night before they have their surgery or their RAVU before they have their procedure. So I would probably see if there's a way to delay the surgery to get them onto treatment and then go ahead with the surgery. But I think it was a fascinating question.
Then there is a question, a colleague who thanks us for an excellent lecture and asks, what is your experience about CAD in children? The answer is, my experience with CAD in children is that it doesn't exist. Cold agglutinin-mediated autoimmune hemolytic anemia in children is always CAS.
Yeah.
And you should be aware of also the PCH to confirm or exclude PCH by doing a Donat-Landsteiner test. And then I think the next question has actually already been answered. Do you reserve sutimlimab after rituximab or give it in the first line? I think you answered that already.
I think, again, you have to decide what's making the patient sickest. And the most rapid treatment or rapid effect would be with sutimlimab.
And then there is a question. I have a 65-year-old CLL stage 0, with cold agglutinin hemolytic anemia. Do you think it's secondary to CLL, or is it a primary cold agglutinin disease? Again, if this is a CLL, so-called CLL, with only a CLL lymphoma or SLL in the bone marrow, and the patient does not meet the hematological criteria for CLL, then I will question the diagnosis. Is it a CLL lymphoma, or is it a CAD-associated LPD? So it may be a primary CAD. In addition, the differentiation has probably no consequences, because a CLL, which you see only as a bone marrow disease with no clinical manifestations, not even being a stage 1, stage A, then the CLL should not be treated by itself. It's the hemolytic disease that should be treated in that patient. And I think to treat the patient as primary CAD will work perfectly well if you choose sutimlimab or B-cell directed treatment, depending on the patient characteristics. Then I have a question here, which I think I will pass to Dr. Weitz. Is CAD associated with increased mortality?
Yes, it is. And that's why untreated, these patients they probably die of thromboembolic complications as well as profound anemia with cardiovascular complications. And
then there was an interesting question. What is the prevalence of cod in Latin America? Well, to be very honest and
We don't know.
somewhat nihilistic, my answer is that I don't know. I have never conducted any such studies in Latin America. So if anyone has, please tell me the results. But what we have done, we have done studies where we compared the epidemiology in northern Italy with Norway. And even though the difference in climate isn't vast, there is an average difference of 7 degrees Celsius. The difference in cod epidemiology was vast. We had 4 times higher incidence in Norway and 4 times higher prevalence. That is incidence and prevalence for patients diagnosed with cold agglutinin disease, of course. So I assume that the prevalence and incidence of patients with symptomatic cold agglutinin disease in Latin America is very low, maybe with the exception of Patagonia.
Or Chile, where they have big mountains. It gets cold. Yeah.
And then well, the next question is, we are out of time. Okay.
Thank you all for staying and paying attention.
Thank you for reminding us.
We hope you learned something.